Good afternoon, everyone. Welcome to our special live program on Cancer Reach. Cancer Reach is initiated by Dr. Krishnamani to spread awareness about the cancer and help the caregivers and patient to access the right treatment on right time. Thank you all of you for joining us today and also being a part of Bladder Cancer Awareness Month, which is our this month. So if you remember in our last session, we had a discussion or we have learned so many learning points for what is exactly a bladder cancer is, what are the types, risks, symptoms, diagnosis, techniques, etc. Many things we have discussed in our last session. So in the continuation to that session, today let's understand about the management of bladder cancer. We have our honorable guest or distinguished guest who has more than 10 years of experience in the field of oncology, particularly in the management of tobacco-related cancers. So please join me in welcoming Dr. Krishnamani, who is associated with American Oncology Institute of Hyderabad. Thank you, Doctor, for joining us today.
Thank you so much. Good afternoon and welcome everyone to Cancer Reach. As we all always say, Cancer Reach is an initiative to spread awareness about cancer. So today, as you just said, this will be a culminating session on management of bladder cancers. Last week, we have discussed on what causes bladder cancer, how common is it, what are the symptoms which our people should watch out for, and what are the tests to diagnose, which include a urine cytology, cystoscopy, CT scans. Now, we would like to go deeper into how, if a person is diagnosed with bladder cancer, how he or she should be managed.
Thank you, Doctor. Actually, even frankly speaking, I was eagerly waiting for this session because so many questions were unanswered in the last session. So this session is the right time to get answers for those. So, Doctor, like in the continuation, what are the factors to individualize treatment in bladder cancer, Doctor?
So, see, when we talk about any cancer, when you talk about treatment, right, the basic things which are common for any cancer is, or for any person is, cancer treatment is not the same in everyone. So imagine two people have bladder cancer. You are not going to treat both of them the same way.
Yes.
The treatment will depend on your age, on your comorbidities. That is all whether you have any diabetes or hypertension, heart issues, you're a kidney disease patient or dialysis, etc. What is your stage of bladder cancer? Whether it is non-invasive, invasive, whether it is stage 4 metastatic disease or not. Okay. Your performance status. Performance status means your fitness. So I may be a bladder cancer patient, completely bedridden. So you may not be able to offer chemotherapy for me because I'm bedridden already. I may not be able to tolerate the side effects of chemotherapy. There may be somebody else next to me who is a bladder cancer patient, who's hale and hearty walking, who is stage 1. Okay, or muscle non-invasive. So your treatment is not a one size fits all approach. That's why medicine is called an art, not just science. If it was just science or mathematics, 2 plus 2 will be 4 in all scenarios.
Yes.
Yeah, so medicine has to be personalized. Cancer treatment has to be personalized and individualized. More so, bladder cancer treatment, which will be individualized based on the patient's age, fitness or performance status, background illness or comorbidities like diabetes, hypertension, heart issues, etc., stage of bladder cancer, okay, and whether it is invasive or muscle non-invasive. So these are some of the 5 or 6 important factors which will determine how you're going to manage a patient.
So in short, doctor, whatever the patient is coming, that will be a new learning or a new approach you have to apply for patient to patient, each individual.
It is
So
going to change. And with the advent of immunotherapy now, in certain patients, you can give immunotherapy. In certain patients, you cannot give immunotherapy. For example, immunotherapy is contraindicated in patients who have autoimmune disease, like maybe rheumatoid arthritis or scleroderma. It is not advisable in patients who take high dose of steroids for whatever reason, more commonly rheumatological conditions. So when your treatments are also getting new, indications and contraindications also emerge. So you have to choose. It is not like today the world is going towards immunotherapy, so all bladder cancer patients receive immunotherapy. No. In those bladder cancer patients, there may be somebody who is taking high dose of steroids where you cannot give immunotherapy. Somebody may be a severely peptic ulcer disease patient where immunotherapy, where steroids cannot be given. Okay. So there are a lot of things like that. Somebody would have been given immunotherapy for some other cancer.
Hmm.
You have to take that into consideration. Somebody may be having tremendous side effects due to the first dose of immunotherapy itself, so you cannot re-challenge with immunotherapy. So the treatment individualization also is not a one-day process. It is a continuous process. Day one, when you see the patient, you will not say, this I will give you and it stops here. And from today, whatever I have told you on day one, that will continue. No. Next cycle, you have to assess the toxicity, assess the response, assess the tolerance, based on which you will go ahead.
Oh my God, doctor, is quite a tricky decision to make for any individual. So, doctor, like you were talking something on muscle non-invasive cancer. Can you just brief on like what is the treatment involved for muscle non-invasive cancers?
So if you remember last time we had told that
Hmm.
for any cancer you need a biopsy. So for bladder cancer we will do a cystoscopy. We put a camera into the urinary bladder and you do a biopsy.
Hmm.
On the biopsy you should see muscle. The pathologist has to report muscle. That is muscle is there in the tissue.
Okay.
Okay? It's like when you have a wall you should have a brick.
Yes.
Very simple. So when we have done a biopsy there should be muscle.
Hmm.
Whether the tumor is before the muscle or growing through and through the muscle, this is muscle non-invasive. It is not touching the muscle.
Okay.
So my tumor may be non-muscle invasive. Somebody else's tumor may be muscle invasive. This will decide. So this is T1.
Hmm.
T1. This becomes T2.
Okay.
If it goes into the fat, it becomes T3. If it
Hmm.
goes into the nearby areas outside the bladder, it becomes T4. So muscle invasive is T2 plus. That is T2, T3,
Oh,
T4.
T4. Okay.
T1 is before the muscle.
Hmm.
So this treatment is different. Those treatments are different. So T1 is different. T2 plus is different. Muscle non-invasive is T1.
Hmm.
Muscle invasive is
T2.
T2 and beyond.
Okay.
So this, so now when you talk about non-muscle invasive, that means you're talking about early stage.
Hmm.
So you have done a biopsy. Muscle is mentioned in the pathology, and the pathologist says the muscle is not touched or the muscle is not involved. So it is
Okay.
non-muscle invasive. It is early disease.
Okay.
In that, people have refined whether it is low risk or intermediate risk or high risk.
Oh,
If
okay.
it is T1,
Hmm.
high grade, the cells look a bit different on microscopy, or it has come back, this patient has come with the same kind of a problem again and again, or
Hmm.
the tumor is sometimes more than 3 centimeters is big, then you make it high risk.
Okay.
If it is less than T1, low grade, very small lesion, it becomes low risk. Anything which is not this or this is becomes intermediate risk. Now, this is extremely complicated oncology.
Exactly.
So broadly again, I would only say there is muscle. If it is beyond it, it is T1. If it goes through, it is
It's
T2 and beyond.
T2 and beyond.
So T1 or muscle non-invasive means we will just do the biopsy and come out.
Hmm.
And we will give one dose of chemotherapy inside the bladder. That is called
Okay.
intravesical chemotherapy.
Okay.
Or sometimes they give BCG vaccine, which is used for tuberculosis.
Hmm.
It is called intravesical BCG instillation.
Okay.
So for muscle non-invasive, the treatment is do the biopsy, give one dose of vaccine, BCG or chemotherapy inside the urinary bladder, not in the blood, not like IV.
Hmm.
Okay. Then if you are a high risk patient, if your disease comes back again and again, then if you have a recurrence, despite all this treatment, sometimes patients say, the doctors say, get a bladder removed. That is called cystectomy.
Oh, okay.
Okay. So
Hmm.
bottom line is muscle non-invasive is early,
Hmm.
is T1. Biopsy is enough, followed by intravesical treatment. In the unfortunate event that it recurs or it is high grade, large
Then,
lesions, then you may think of bladder removal to
okay.
save the patient. Otherwise, most likely, just biopsy and intravesical treatment. Sometimes one dose is enough, or sometimes we give it for 1 year. That
Okay.
will be fine. That is for whatever risk, low or intermediate or high risk.
So, in short, doctor, in the stage one or the T1, the treatment is little bit easy and the survival rate for the patient will be very high.
Survival is better. We try not to remove the bladder all the time.
Hmm.
We just get away with a biopsy.
Hmm.
We divide these patients into low and high risk. So just to, what do you say, to make things easy sometimes to people, high risk means you have a large tumor,
Hmm.
high grade,
Hmm.
comes back again and again, it is T1, those kind of things. Low grade, only once you have disease, it is less than T1,
Hmm.
that is low grade, low risk.
Oh,
Okay. So obviously, the larger the size, more chance of coming back. The chance
yes.
it keeps coming back, then it will come back even more. So
Yes.
based on that, they have divided into risk. But all this is muscle non-invasive. So from a patient point of view, he should look at the pathology report. He should see whether it is crossing the muscle or not. Not
Hmm.
crossing the muscle, it is muscle non-invasive. Get a biopsy, get a intravesical chemo or BCG, and be under regular follow-up with your doctor. Your job is done.
That is
Now
very
comes
much
to the
important.
next question,
Uh,
which is here, I think, muscle.
non-muscle invasive cancer. Actually, I was about to ask that.
Yeah.
Yes.
Muscle invasive means goes beyond the muscle, T2,
Yes.
T3, T4 or node positive.
Yes.
There, the primary treatment of today is chemotherapy first,
Hmm. Oh,
followed by surgery.
oh, okay.
Chemotherapy, if given, and in those patients whom you don't give chemotherapy and directly go for surgery, giving chemotherapy before surgery increases their lifespan.
Okay.
The risk of death decreases by close to 20%.
Hmm.
So, if your tumor has crossed the muscle,
Hmm.
your treatment is, if you are fit, chemo first,
Hmm.
followed by surgery.
Okay.
If you are not fit for chemo, sometimes doctor may take you up for surgery directly and then give chemo. If you don't want surgery, I don't want to remove my urinary bladder. I don't want to undergo a surgery.
Hmm.
Then you will undergo chemo and radiation. So that is a bladder preserving approach. But that will be a plan B. It is not the first plan which you should choose. The first plan should always be in muscle invasive chemo, which is neoadjuvant chemo. That is chemo given prior to surgery, followed by surgery. That is your first planned treatment.
So, in short, doctor, the surgery will be touch wood, it should not happen, but that surgery will be the removal of bladder only.
Yes, there will be a removal of the bladder, urinary bladder. Yeah, as I'm not a surgeon, I'm not very well versed with the surgical techniques. But cystectomy is the standard treatment. That is removal of the bladder.
Uh,
And
so, hmm,
there was a time when that used to be the main treatment. Now, studies have shown giving chemotherapy before bladder removal improves the outcome and survival and reduces the risk of death by close to 20%.
okay. So, doctor, like after the removal of the bladder, the patient will be dependent on some external urinary bag kind of a thing then.
Yes.
Okay, okay. So, doctor, like you, in this, doctor, in the first, when you are talking about non-invasive, what is that metastatic cancer? That can you brief on that
What is
metastatic?
metastatic? So we spoke about disease which is either very early or just within the bladder or outside the bladder. Metastatic means it has gone beyond the bladder. It's
Okay,
gone to the bone, lung, liver, brain.
we can say it as a T4, doctor.
It is stage 4, not T4. T4
Okay,
is if you cut your bladder like an onion,
okay,
how
okay,
much the tumor has gone within the wall, that is T1, T2, T3,
T3.
and T4. Stage
Okay,
4 means it has spread everywhere.
oh,
T1, T4 is up to the bladder only you are talking.
okay.
Imagine the urinary bladder like an onion, cut it into concentric circles.
Hmm.
T1 is not touching the muscle. T2 touches the muscle and goes beyond. T3 goes into the fat. T4, if this is the outer part of the bladder, T4 is growing, crossing the bladder and going out. So T1, T2, T3, T4
Yes.
going out of the
Yes.
bladder.
Hmm.
Okay. Stage 4 is metastasis. It has spread
Okay.
beyond the bladder. It has gone to the lung. It has gone to the liver. It has gone to the brain. It has gone to the bone.
Hmm. So, doctor, if when the it is on a metastatic cancer, so then what are the options, or the what are the treatment you will prefer for those set of patients then?
See, what we should understand is metastatic cancers are generally not curable.
Yes, it has spread. Yeah.
The treatment of choice is systemic therapy. That is treatment given via blood. That can be chemotherapy, that can be
Hmm.
immunotherapy, that can be targeted therapy, that can be antibody drug conjugates.
Okay.
So, any chemical given through the blood which acts on the cancer cell,
Hmm.
either chemo or immuno or targeted or ADC, antibody drug conjugates. This is in stage 4. This is not curable.
Hmm.
The intention is not cure, it is palliation. If nobody is going to say, I'm going to cure you here. The aim is to control the disease burden, reduce the volume of disease, reduce the suffering, improve the quality of life, and at the end, prolong the survival with minimal side effects.
Hmm.
The aim is not to give you side effects to put you on bed. Aim here is not to cure you. Cure is not possible. Control is possible. Reducing suffering, improving quality of life, reducing disease burden, volume of disease, and improving survival.
Okay.
These are the basic aims in stage 4 or metastatic setting where the treatment is palliative.
Oh. So, doctor, like when you were explaining about the treatment types, you mentioned the word called immunotherapy. Can you just brief me the little bit more about immunotherapy in bladder cancer?
So for that, you should first know the history of the treatment of metastatic bladder cancer.
Okay.
So chemotherapy has been the cornerstone in treatment.
Yes.
Chemotherapy is a cancer killing or controlling drug.
Yes.
In bladder cancer, even today, chemotherapy is the most commonly used medicine for stage 4.
Mm.
What medicines we give? There was a regimen called MVAC, which we used to give
Mm.
earlier. Now we use a regimen called gemcitabine cisplatin. This is name of the drug only that your oncologist will take care. You don't break, we should not break our head. So chemotherapy is still the backbone.
Mm.
Gemcitabine cisplatin is commonly used. Earlier it used to be
Okay.
MVAC. These are name of chemotherapy drugs. Side effects, as we all know, nausea, vomiting, loss of taste, loss of hair, weakness. Okay,
Yes.
we may have some tingling in the palms and soles. We may have some tinnitus or hearing issues.
Mm.
Fall in WBC count, fall in hemoglobin, fall in platelet count, infections, fever, etc.
Mm.
Like any chemotherapy. Then we realized immunotherapy also may play a role. So in patients whose disease was controlled after chemotherapy, they gave immunotherapy. That was called maintenance immunotherapy. To
Okay.
maintain, to control, give
Good.
some medicine. Chemo cannot be given continuously because chemo will have harmful effects on your body. So immunotherapy was given.
Okay.
Then they realized,
Mm.
why don't we give immunotherapy before chemotherapy? You are giving chemo,
Yes.
results are okay. You are keeping immunotherapy as maintenance. Why not push it here?
Start with
Let
immunotherapy.
us see how it compares with chemotherapy.
Mm.
So today, immunotherapy plus another medicine called ADC, antibody drug conjugate. What is
Okay.
that? So immunotherapy means it's a medicine which boosts your immunity to kill the cancer cell.
Okay. Yes. Mm.
ADC means there is an antibody,
Mm.
there is a drug, and in between there is a linker. So it is
Mm.
like this
Mm.
antibody drug which is attached by a linker.
Yes.
This
Okay.
linker here. Okay. So the linker takes the antibody and the drug
Mm.
and goes to the cancer cell,
Mm.
releases the drug to kill the cancer cell. So today, combination of immunotherapy plus ADC, there is a drug called enfortumab vedotin plus pembrolizumab.
Hmm.
Enfortumab vedotin is ADC, pembrolizumab is immunotherapy. The combination of these two is superior to chemotherapy when given upfront. That is first line when somebody is diagnosed with stage 4 bladder cancer. So many years chemotherapy was the number one. Today that position has been challenged, and today the standard of care is ADC plus immunotherapy. But in those
Yeah.
countries where these medicines are not affordable, or those patients who cannot afford, sorry, the medicine is not available in those countries, or patients who cannot afford, or patients who have side effects for these drugs,
Hmm.
there you will use chemotherapy.
Okay.
So we have looked at the history of bladder cancer. We started with MVAC. We have gone to gemcitabine, cisplatin. They are chemotherapies. They are given for fixed number of cycles. Then immunotherapy maintenance came into picture. Then immunotherapy came in first line with ADC. And today this is the number one. This is the standard of care. If it is not available, if patients cannot afford, if there is toxicity, then you will not give enfortumab and pembro. You will go for chemotherapy.
Oh. So in short, doctor, the you can say the practice or the medicine, um, like latest study or the latest approach, immunotherapy is better than chemotherapy, and obviously the results are also better with
Immunotherapy
immunotherapy
and ADC
AD.
results are much better, almost double the survival, almost
Okay.
60-70% reduction in the risk of death,
Oh wow. Okay.
but mindful of certain side effects. Immunotherapy side effects we know. We know there are thyroid problems, there are pancreas issues, there are
Hmm.
skin problems, there is gut diarrhea, etc. Enfortumab can cause eye issues. You can
Okay.
have blurring of the vision, you can have watering, you can have corneal ulceration,
Okay.
keratitis, we say corneal inflammation, etc.
Hmm.
Enfortumab can cause serious skin infections.
Okay.
Okay, so these are the issues with the enfortumab can cause some pulmonary or lung infections also, lung inflammation, ILD we say.
Hmm.
So just because a drug is there and it is not chemotherapy, it doesn't mean it has no side effects. They have their own set of side effects because at the end of the day, that also is a chemical.
But sir, even like even earlier also, even with the chemotherapy drugs also, the side effects are very high.
Yes.
So,
So now when we are learning new things, we should also learn the new side effects. We see the new side effects. So that also we should learn how to adapt.
but there is a treatment available for those side effects also,
Yes,
like.
you will reduce the dose, you will give some dose of
Hmm.
steroids. We have learned to manage those. So trial and error basis, and there are strict guidelines also now on how
Hmm.
to manage immunotherapy related. We call it IRAE, immunotherapy related adverse event.
Okay. Anyhow, this is the, you can say, the technology or the science or the treatment which has evolved. So, doctor, like right now you were mentioning something called antibody drug conjugate. Can you please brief us a little bit more about it?
So that's what we discussed. So there is a link, there is an antibody, there is a drug which is joined by a linker.
Yes.
So this goes and delivers the drug inside, and the drug kills the cancer cell, to put it very simple.
Okay.
Nowadays, you see antibody drug conjugates in breast cancer, you're seeing it in bladder cancer.
Hmm.
Okay. So in bladder cancer, the drug's name is called enfortumab vedotin,
Hmm.
and it is given along with immunotherapy. And if there is a response, both these drugs are continued,
Oh,
unlike chemotherapy, which is stopped at a fixed number of cycles.
okay.
But enfortumab has its own issues in the form of eye, lung, and skin
Lungs.
toxicity. Be mindful of that.
Okay, but at least the patient survival rate is increased with this immunotherapy and antibody drug conjugates.
Yes. For a long while, we were stuck
Hmm.
with chemotherapy, which was giving same kind of results.
Hmm.
Now we have taken a jump.
Oh, wow.
But in our country, these medicines are expensive. They are out of reach of the common man. Generics are not available. Patents are still in place. They are new drugs. So it will
Yes.
take time for the real benefit to reach the common Indian.
In fact, doctor, as this month is dedicated for a bladder cancer awareness, the wish should be like the people should stop smoking.
Correct.
That will automatically take care of the
Reduce,
bladder cancer.
reduce a lot of cases of bladder cancer.
Yes. So instead of dreaming of hearding of that the prices coming less or generic coming into the market so the treatment can be reduced, instead of that we can dream of reducing the smoking condition anti-tobacco awareness, and we can reduce the bladder cancer outcome also.
We ought to do that. We must do it. Bladder cancer, what do you say, has to be prevented. Smoking has to stop. Our people should lead healthy lives. We cannot afford to smoke and get all these kinds of cancers and then spend on their investigations and treatment. And then there is
Exactly.
morbidity, surgery,
Yes.
radiation, and it is not an easy thing. A lot of
Yes.
morbidity, death, and all that. So it is not required. What can be prevented has to be prevented.
So, like now, when you were talking about the bladder cancer treatment, after that, if the bag is removed, and also after chemotherapy, immunotherapy, and antibody drug conjugate, can you approximately guess what will be the lifespan or the of the patient?
Today, metastatic disease with ADC conjugates and all that, the lifespan has gone up to beyond 2 years.
Okay.
So it's a close to 2.5, 3 years. So that's
Huh.
a good significant step.
Yes.
That's a significant step. The early
Okay.
stage bladder cancers will do extremely well. They just need to be under follow-up.
Yeah.
Maybe 6 monthly cytology, yearly cystoscopy.
Hmm.
The T2 to T4 muscle invasive may need 3 monthly cytology, six
Hmm.
monthly cystoscopy for the
Hmm.
first 2 years, and after that, yearly cystoscopy for 2, 3 years continuously. So be under regular follow-up, show your doctor, get your cytologies done as advised,
Hmm.
cystoscopy as advised. Any
Hmm.
symptom, report to your doctor,
Hmm.
hydrate yourself well. Sometimes concentrated urine can appear as blood in the urine. That's because you're taking
Ah,
little water. So
yes.
hydrate well. Okay, all the urine which is it may have a reddish hue, but it's actually deeply concentrated urine because you have not taken enough amount of water.
What? Yes.
That's a small health tip. Otherwise, nothing major. Quit smoking, and then I think we have solved the puzzle.
Very true, sir. Like the for a tree to grow, seed is a reason. So to stop the bladder cancer, smoking is the reason. So if we
True. I
stop,
agree with you.
yeah,
Can't agree more.
exactly. Actually, doctor, this was quite an interesting topic. I am like we have came to end of the session. Thank you very much, doctor, for your valuable time. But this is really a learning for all the people and easy to understand, easy to realize how smoking can lead to bladder cancer.
Yeah, so basically, we have spoken about smoking, we have spoken about tea staging, we have spoken
Yes.
about muscle invasive, non-invasive, we have spoken about immunotherapy, ADC, chemotherapy.
Hmm.
Literally, this is like an oncology class session for any medical student. So we have gone into good depth, I say.
Yes,
So in that way, I'm happy that we have tried to cover most issues.
it's a very informative session, doctor. You won't believe a common people might not understand the drug molecule or the drug related, but the brief whatever is given will be very helpful for a person, also for the patient and also for the caregivers.
True, true.
Thank you, doctor. Thank you very much for this interesting session on bladder cancer and your valuable time, doctor. Doctor,
Thank you
would you
so
like
much.
to give some closing message to the audience?
The closing message would be very simple, as you said. It is an important cancer. Let's quit smoking. Let's
Hmm.
prevent bladder cancer. Let's understand that early stage bladder cancers are extremely curable. Just a biopsy, tumor resection, we call it TURBT, transurethral resection of the bladder tumor with
Hmm.
intra-bladder or intravesical chemotherapy will solve the trick. And you need to be under regular follow-up. Even the muscle invasive patients, surgery and prior to surgery, chemotherapy would be the treatment of choice. If you
Hmm.
have a discussion with your doctor, if you want a bladder sparing approach, then radiation will be advised. Metastatic patients, they do poorly. Chemotherapy is still commonly used, but immunotherapy and ADCs are challenging or have challenged chemo already, and these patients are doing much better. Yeah. So I think with this, we should be able to fight bladder cancer, and obviously, great people are doing significant research so that our patients benefit from all of this.
Yes. Thank you, doctor. Thanks a lot. Thank you, everybody. And also, the small message is like quit smoking and also spread the awareness for bladder cancer in the month of May. So, wishing you all strength, hope, and good health from Cancer is. Thank you, everybody.